morning. Thank you very much for having me here, Vincente, Elena, and here. And it's and Gloria and others in the room who have been very good hosts for me for the last couple of weeks here in Madrid and as well as in San Sebastian. And I guess in the next few days I will be getting to spend more time with some of the Spanish longitudinal study and aging folks to discuss additional things, and especially with Ankel and others. I'm not going to be presenting any data today. We do have some, we are recruiting people into our study and we are generating data, but here I'm going to be mostly talking about the design and some of the issues that we faced as we were designing, and that might be of some value to the Spanish longitudinal study on aging as well. If I start speaking too fast or I start not speaking too loud, just raise your hand and ask me to slow down or speak up. I'll try to speak slow so people can follow me. I guess one of the key features, I think, for our study, the Canadian longitudinal study on aging, and affectionately we call it CLSA, is a key strategic initiative of our health funding agency, which is called Canadian Institutes for Health Research. That's what I will refer to CIHR here. And when I say that it is a key strategic initiative, what does that mean? That means is that it is a budget line item for the funding agency for the next 20 years. That doesn't mean that we will have the funding from them every 5 years. We have to show the progress, we have to go through repeated peer reviews. As long as it's reasonable progress, they will find the resources. And I think that's an important piece that you need to sustain a study for the next 20 years. Now, having said that, some of you in this room also know that it took us 10 years to get the study off the ground. So we were in development, in discussion, in working with the government, working with the funding agency, working with many partners to get it to be a strategic initiative within our funding agency. It is a national study. There are more than 160 researchers across 26 institutions in Canada involved. Now, it sounds really impressive that there are 160 researchers. In reality, you know, only 2 people really do the work. But in this case, we have a core team of 60 or so people who actually did most of the work, and others were more collaborators whenever we needed them for something else, something we needed, we brought them forward. But generally, 160 people get credit for this grant, and 60 people do the work. I should be careful, you're recording this, right? And it is a multidisciplinary study, similar to as what Javier was discussing, the Spanish longitudinal study, and Vincente was talking about. We have biologists, geneticists, physicians, psychologists, sociologists, demographers, economists, epidemiologists, nursing, nutrition, lifestyle and behavior, health services, and so on and so forth. It's really simple to list them on a slide, but this was probably the hardest part of developing the protocol for our study. Bringing people together and getting them to work together and understand each other's language. It took 2 years to get us to convince people that this was not a clinical study, it was not an economic study, it was not a sociology study, it was an interdisciplinary study, and all those pieces had to be represented in a way that sort of creates a new and unique initiative. Other concept of the Canadian longitudinal study on aging, and this is a new thing in Canada. I think Europe has had a bit more of a history in relation to research platforms. And also, there is not a very long history of longitudinal studies in Canada. This is one of the largest longitudinal studies funded. Whereas you will hear later on about the CLSA, UK has a lot longer history of longitudinal studies and interdisciplinary studies and people working together. So the idea was that we are going to develop a longitudinal study on aging, which is going to be a research platform. Now, on one hand, we say Canadian Longitudinal Study on Aging. We label it as a study, but we have designed it as a platform. I'm one of the principal investigators of the study. I have no special access to data. I have to access the data the same way any one of you could apply and get the data from the study. We have special committees that evaluate the proposals that come in, and people get access to data. So it's truly a research platform. We wanted the data to be used by many, many people, and that was the motivation behind this initiative. And general aim, very high level aim of the study was to try to understand the dynamic processes of aging. We didn't want to be another disease study. There are lots of disease related studies or disease specific studies available in Canada. We wanted to understand the process of aging in a longitudinal fashion and trying to look at how biological or internal factors relate, interact with external factors to define the transitions and trajectories of aging. So when we were thinking about this initiative, I'm not going to go with the historical context of the study, how we came to this. We actually wanted to have a study that sort of went from biological, cellular understanding of aging to social understanding of aging. And the other thing that we wanted to do, ideally, we would have liked to see a much younger cohort enroll babies into the study and the older people and the oldest people and follow them. But there was no way we were going to get a study that would have included all the age groups and get it funded. So we had to make certain decisions. So we started to think about understanding aging process from an adult development perspective. And that was the framework that, in a way, drove the development and the construction of this initiative. And secondly, we wanted to focus on midlife because we were interested in baby boomers, because that's one of the biggest projected cohort that is going to be becoming older, and we know that baby boomers are very different from the older people of the today. Their expectations, their requirements, their needs are going to be very different, and they're politically much more knowledgeable. So they are going to put some pressure on governments and policymakers that today's older people don't. I will come back and spend a little bit more time on the quantitative traits a little later. And basically what we were interested in the context of the quantitative trait is that we wanted to be able to look at some of the biological relationships in a way that doesn't require very large sample sizes. So the concept of quantitative trait was considered. Other studies have done it. UK Biobank in UK has looked at creating a sub-cohort within their cohort of 500,000 people where they're specifically focusing on some of the quantitative traits. What do I mean by quantitative trait? We could look at diabetes as an outcome, yes, no, which might, if we are looking at a relationship between a gene, which is very rare, or environmental exposure, which is very rare, you could acquire very large sample sizes to get enough events to be able to look at that interaction. Whereas if you look at a quantitative trait such as glucose and changes in glucose, you can actually look at that interaction between the genetic and the environment with a lot smaller sample size. So we sort of thought about this. This was the balancing act between what could we do realistically, what funding we could get, and what other ways we can think about designing the study. And this was one of the ways we sort of dealt with the sample size issue. Now, I have to say that we are not a big G gene environment study. We are a small g. Our focus is not specifically looking at genetics, but we have opportunity to look at gene-environment interaction where we can. But I don't want to mislead anyone that we are actually going to go and solve all the gene-environment type of relationships. We will be able to do some, but many we will not be able to do. And in any study of aging, it's difficult not to look at diseases, but that was not our primary driver. Diseases are going to be part of the data collection. We are going to be looking at disease outcomes, but we really wanted to understand the trajectories related to function and disability, and what are the psychosocial consequences of these things as people live. And another area which has been really understudied in aging specifically is the notion of adaptation. We all age, we all have positive and negative experiences, but we all, one way or another, adapt, and that adaptation allows us to take certain trajectories. So the question is, how do you measure adaptation and try to manage that in your own study? So this was one of the areas that we thought we will take on and try to look at that in this study. The adaptations could be biological, adaptations could be psychological, they could be social, or they can be structural. Like the whole community might adapt to accommodate the older people and how they live and how they function. And there are some really interesting examples of that. And biological adaptation, one of the ways we are looking in this study is something called epigenetics, which is saying that biologically body adapts to some sort of external stimuli, whether it's a negative adaptation or a positive adaptation, that has consequences, what happens to the biological functioning of the system or the body, and has an impact on certain outcomes. So if we have chance to discuss, we can discuss this piece a little bit more later. So there were many objectives and hypotheses and research questions that were developed. And we actually decided at the end of the day that the study was going to be built around a core set of research questions, but we had to keep in mind that it was going to serve as a platform for the larger community of researchers. I'm not personally a big fan of developing studies that don't have any research questions. I think there needs to be some set of research questions that define some parameters, but based on that, then you can also create a larger framework or a platform. I'm not going to have time to go through very specific research questions or hypotheses that we have posed, but they were all within these areas of the overall research. For example, we were interested in progression of health from middle age to early old age to older old age. We are interested in determinants of well-being and quality of life. We are interested in risk factors, and I'm an epidemiologist. I love risk factors. One way or another, we end up studying. Cognitive functioning and mental health, looking at the concept of disability and compression or decompression of morbidity. Looking at socioeconomic and health inequalities, social participation, social relationships, and retirement and post-retirement, and economics and wealth, and those types of initiatives. And lifestyle issues also come into play. So what is a Canadian longitudinal study on aging? It is a cohort of 50,000 people. So it's a fairly, I would say, probably internationally, this will be the largest aging cohort. There are larger cohorts that are focused on looking at risk factors of diseases and things like that, but something that is designed around aging or aging-related issues or aging-related processes, this is, I think, the largest. Now, if there are Swedish people in the room, they might say they have a larger cohort, which is highly possible because they have lots of already registries they can link and look at different things. But the primary data collection, I think we are one of the largest ones, if not the largest. So it's a cohort of 50,000 people, and all 50,000 people are going to provide data using questionnaire. And I'll go into a little bit more detail how we have divided up this cohort of 50,000 into two different types of measurements. And as Canada has a universal health care, that means that everybody who's a resident of the country gets a health card number and they have free access, well, not necessarily free, we all pay taxes, but everybody has equal access to the healthcare system. So anytime they have an interaction with the healthcare system, whatever service they receive gets recorded into a registry at each provincial level. So we are asking people to give us their health card number, and then we will be able to link individual level data with their physician encounter database, their hospitalization database, their drug databases, and also in some provinces we have home care and mental health databases as well. And we will follow these people for the next 20 years. And each person will be contacted for the main data collection every 3 years. And it's important for me to point out that we are slightly different in our age group in relation to the Spanish longitudinal study on aging, or later on you will hear about the CLSA, that at the baseline we are recruiting between the ages of 45 and 85. We are not including 85 plus people in our cohort. And there are several reasons, and if we have time we can go into discussion about our decision not to include the oldest cohort at this point in time. That doesn't mean that we will not have another sub-cohort that will focus on that population. This is a map of Canada, and this is East Coast, that's West Coast, and that is the frozen part of Canada up there, but there are a few people living there. And so we are selecting people from every province, but not the territories. And territories are on top part of Canada. And there are very specific reasons for there. Most of the territories have Aboriginal populations, and Aboriginal populations have specific Aboriginal status. And in order to do any research in Aboriginal communities, you have to work with the community to develop the research question, and that can take a very long time. So we decided our core study will not focus on that population. Once we have developed a core study, then we will work with the communities and develop a parallel cohort that will use some of the measures that we have, but will focus on the specific issues of those communities. And second part is that the cohort in those communities are a lot younger. Their aging process in those communities is actually quite different. Their dementias happen a lot earlier. There are higher prevalence of diabetes and some of the other cardiovascular related events. So the questions were different, so we decided that we will not focus on that population at this point in time. Now, turned out to be, it is a very political decision. We will have to address that population sooner or later, but at this point in time, we are not. So the 20,000 of the 50,000 people are a random sample of the Canadian population, except for the remote areas. Okay? And this is what our National Statistical Agency also does when they conduct surveys which are designed for public health policy or public policy. So just keep in mind that 20,000 of the people are a random sample of the Canadian population, and these 20,000 people only provide data by a questionnaire, which is a telephone administered questionnaire. And this particular cohort, or the sub-cohort from the 50,000, was created to provide regional or provincial level estimates for the public health or the policymakers. So it was a strategic decision on our part, because in order for this study to be continually funded and have attention within the political arena, we wanted to create a data set that will provide information regularly for the policymakers at the federal as well as the provincial level. And I also want to stress that we cannot go lower than the province level to give them the estimates that in which we have any confidence. So we cannot go at the regional health authority level in this cohort. So the remaining, I forgot to mention something here. So I said that we are following people every 3 years. That is every 3 years we are collecting full the constellation of our questions. But in between each wave of the study, at 18 months, we contact every participant, all 50,000, by telephone to make sure that they haven't moved, just to maintain contact, to minimize the loss to follow-up. But we also collect additional 30 minutes or 25 minutes of data from these individuals. And you will see why we have done it. And it was also sort of built as a strategic data collection tool that somewhere along the line some policymaker or minister or someone comes and says that we would like some data, cross-sectional data, for a particular point in time for policy making. We can use that aspect of study to collect additional data and provide that data in a quick fashion to the potential users of the data, specifically policymakers. So the remaining 30,000 is what so you will hear me now, the 20,000, which is the random sample of the population, we call it a tracking cohort, just to make it differentiate. No specific reason, we call it tracking cohort. The more in-depth cohort, which is the 30,000 people, we call it comprehensive cohort. And it's also important to know that the 30,000 cohort and the 20,000 cohort also have questions that we ask that are common, and our sampling statistician have come up with a way to pool the data of the 30,000 and the 20,000 to create a 50,000 people cohort where the questions are common questions. Okay? So this comprehensive cohort, which is based on the 30,000 people, is it's a national cohort, but not nationally representative cohort. Okay? So what it is that we have 11 sites across the country from which we select individuals for the study, and then they go through an in-depth data collection. And I'll take a few extra minutes a little bit later to how do we do that sample selection. And the sites we have go from east to west coast, and the sites that we have picked are large urban centers which have large heterogeneity, ethnic heterogeneity, as well as small centers that are quite rural. So we have a gradient of rural to urban, but we do not, again, include any remote areas because it's very difficult to access those areas and collect some of these data. So the longitudinal study, I said the tracking is 20,000, comprehensive is 30,000. These are our age groups, and these are the distributions of the sample sizes in each one of these groups. So since we were interested in looking at transitions and trajectories, that was our driver, we are a little bit heavy on the younger age groups as compared to the older age groups in this study. So that was by design. And when we were designing this initiative, and I thought I'd put this slide up here for the purposes of the discussion, is that we had, and I think Javier mentioned this, I tried to follow him in his Spanish presentation, and I kept hearing my name here and there, and I kept hearing the word collaboration and multidisciplinary teams, and I assumed he was talking about this. And basically we had to think about what key research questions will drive the data collection. And we also had to balance the notion of a platform. So we had to include measures that will meet the needs of a larger research community. So for example, here I will use an example that we knew in our main hypothesis-driven measurement exercise. In this study, we will not be able to specifically diagnose Parkinson's disease. And it is an important disease for the Canadian context because there are very little prevalence or incidence data available. So what in that situation, we said we will put series of screening questions that identify Parkinsonism, but not specifically Parkinson. Once we have identified, people can go and do sub-studies and take those people to neurological clinics to do more in-depth assessment to diagnose whether somebody has a disease or not. And we have several examples of like that in the study. And we also, and also to mention that when we were designing our content, we actually created different working groups. We had a psychology working group, social working group, biology working group, health services, health outcomes, clinical, lifestyle, behavior, and nutrition. And that was when we had our scientific hat. That's what we thought was important. And soon, in 2 years into the study, we realized that if we were going to get funded and have any hope of getting this study off the ground, we had to create a policy working group. So we brought policymakers from provincial and federal governments, and that's where the idea of the tracking cohort or the 20,000 cohort came, because they were looking for those types of answers, and we wanted to make sure that this study was going to be of relevance to them. So on one hand, we were addressing questions that were of relevance to the policymakers, and on the other hand, we wanted to look at how we understand the underlying processes of aging and looking at more mechanistic or etiological type of work. And we also wanted to include measures that allowed us to do some embedded studies that were not part of the core study. And we also wanted to include measures that were able to measure change over time. We were not going to have measures in the study that were designed to be cross-sectional in nature. And the debate ensued whether we wanted to do every 2 years, every 3 years, every 4 years. And we actually did some simulation work to see how our sample sizes, the minimum detectable odds ratios or hazard ratios would be affected by whether we did more frequent measurement versus 2-year measurement versus 3-year. At the end, it was a scientific decision as well as a logistics and economic decisions that we couldn't afford any less than 3 years. And the simulation models that we did showed that the gain was actually not that big unless you were looking at very specific changes that happen in oldest age group in a very short period of time. And that was one of the reasons we decided that 85 plus cohort will have to be designed differently, because the frequency of measurement might be a lot shorter in that cohort. And also, we kept in mind that we wanted to harmonize with other existing studies across the globe. Studies like CLSA, HRS, and there are other studies that we have been working with and considering what level, keeping the innovation and uniqueness of the study and the context of the Canada, but at the same time trying to design study that is able to harmonize with other studies and pool data and address some questions that might be cross-jurisdictional, cross-national in nature, or if we are looking at some biological questions that might require replication in other populations, that we can do. So this is what the depth and the breadth of the CLSA is, and we are looking at a lot of physical and cognitive measurements. I will not spend time in going through this in detail here, but you can see we have lots of measures that are based on questionnaire. We also have a lot of clinical and physical assessment in our study. I noticed that in your measurement there was nothing much about oral health, and I think that is an important piece to consider in an aging study, especially when you're looking at nutrition. Oral health and nutrition are an important, because some people don't eat well, not that they don't have food, they just can't chew some of the food or eat some of the food. So I will suggest that that would be something, emerging area that you should consider. And on the psychosocial side, we have, and I will show you a bit more, some pictorials of the other measurements, which are much more physical assessments. in our study. And one of the areas that we focused on, which is the chronic disease symptoms, we looked at 11 different chronic diseases in the study. And when we consulted with many other longitudinal studies or cohort studies across the world, one of the advice we got, and I hope there are not many physicians in the room, and this is not meant to be pejorative in any fashion, but we were just generally got the impression that the physicians are very hard to standardize because they bring their clinical context in providing data, whereas in studies like this, you need a fair bit of standardization in order for you to have a good quality data. And the recommendation was that use other means to have the information on the diagnosis of the disease. And one thing we could have done was to get diagnosis of disease from our healthcare registries. But we also know that those are not very reliable because in Canada, family physicians, they use 5 diagnostic codes to bill everything. So the accuracy of that information is not very good. So we actually consulted with other studies, other experts, and we developed what we call disease algorithms. An example of the disease algorithm is this. So we have a self-report of physician diagnosed from the participant, and then we go and look at their medication, and we go to the homes of the people, we ask them to bring all their medication bottles, and we record the information directly off the bottle. And then we see what medications they're taking. Then we have blood samples, in this case, fasting plasma glucose or hemoglobin A1C, which are the markers of diabetes. And we sort of go through this tree type of a decision sort of tool. And at the end, we define whether somebody has definite diabetes, no diabetes, or probable diabetes. And we developed 11 algorithms like this, which we went and validated against the clinical diagnosis, and they perform quite well. And other studies have used it. In Chianti study has used it, Women's and Health and Aging studies, and several other studies have used it. I don't know if ELSA uses this framework, but other studies do. So we did a lot of pilot work around this area. And on the side of psychosocial, we have fairly long tool measurements on social participation, social networks, caregiving, care receiving, psychological measures, work to retirement, job demand, retirement planning, social inequalities, mobility. And this was looking at how people move in their environment, whether inside their home, in their near neighborhood or extended neighborhood. And wealth and income modules and the retirement modules were developed in collaboration with HRS. These are not lengthy modules as HRS has, but these are the key essential measures that will allow us to harmonize our data if we need to do some cross-jurisdictional analysis. And by harmonizing with HRS, we are harmonizing to some extent with ELSA and SHARE and others as well. And then again, the usual suspects in relation to lifestyle and socio-demographic data. And we also collect biological samples. We collect 50 ml of blood from every person, and this blood collection will happen every 3 years. And then different fractionations are created. The usual suspect are plasma and serum. We also do whole blood. We also do DNA, dry spots for DNA. But we do 2 other things. One is the cells. We drive cells, which are dead cells, and the live cells that allow us to do epigenetic studies as well as immunological studies and analysis for mRNA. No, I'm not a biologist. Don't ask me any questions about that. But these are the different pieces of information that we are gathering and the urine sample. I also want to emphasize that we have no money to analyze any of this data at this point. All the money we have is to collect data. So all of this is going to be stored in a repository. And one of the key features, I think, of our study, which is working out so far, is that in biological samples are actually very difficult to manage in a large study. And most studies end up collecting blood, and by the time they process and freeze, it's 48 to 72 hours. In our study, from body to frozen state is within 2 hours. And we have been able to achieve that, and I'll show you how we were able to do it. So the first 20,000 we have, I won't go into the detail how we are selecting these people. We have already recruited, this slide is already outdated, we are up to 7,000 people now, and they have given full 60-minute telephone interview questionnaire. And we are doing a staged recruitment using census as a sampling frame through Statistics Canada, our health registration client, because I said to you that we have health registries and everybody's registered, and in some provinces where we have a privacy legislations where we are not allowed to touch those databases, we are supplementing the sample through the random digit dialing, and that is going on right now. And the 20,000 cohort will finish at the end of this year, recruitment and the data collection, and the comprehensive cohort will continue until 2014. So we are recruiting 10,000 people per year till end of 2014. And I mentioned that I'll come back to the comprehensive cohort. It is a cohort of 30,000, as I mentioned. So I said that we have developed 11 data collection sites, and these are actually constructed and equipped with equipment specifically for our study. And I will spend a little bit more time on that. And in order for us to be able to afford the study and logistically get people to a dedicated data collection site, we selected our sample from a radius of 25 to 35 kilometers of a given data collection site. And these are the sites that we have, and each site is approximately recruiting 3,000 people. Okay? So for the comprehensive, as I mentioned, that the first batch of 1,000 people per site, that means that 10,000 people per year are going to be recruited between fall 2011 to mid 2012. We are a little behind. I think it will finish end of 2012. And you can see, and this was also by design, because one of the challenges in some of the earlier studies we did were that we sort of go and recruit people in 18 or 19 months, and then we wait for 2 years. Then we go back and recruit the second wave. And what was happening is that we train these people, we let them go, and then we have to rehire the staff and retrain them. And that was a fairly expensive and loss of very good skill set. So we spread our data collection over a period of time, and you can see that as the main data are being collected, we are going back and doing our 18-month maintaining contact by the end of 2012. So the data collection is constantly happening. So by the time we finish the 2014, we'll be ready to go back for our wave 2 of the study. So it's quite an enterprise. Sometimes I wake up in the middle of the night whether we will be able to do it, but so far it's happening. We'll see how it goes. So just to come back and give you just a bit of an overview. So when we have a recruitment, we have recruited people, we administer consent. For the telephone interview people, the consent is given through telephone, and then they have to mail the signed consent to us. And so they then go and do the telephone interview. And the way we have structured the infrastructure for this study is that McMaster, Hamilton, Ontario, where I am located, is the coordinating center. So all the IT infrastructure is in Hamilton, and all our remote site access the information about the participants and the data when they are being collected electronically in real time are being transmitted back to Hamilton. And our staff in Hamilton, there's staff of around 8 people who are constantly checking the quality of the data, and they sort of continuously communicate with the site supervisor if something they see. And site supervisors are doing exactly the same, but they are not doing as detailed. So our quality control people can hear and see the screen of the interviewer. So they can hear what they're asking, and they can see what is being entered on the computer. And And so these are the softwares that we developed in-house. These are open source. If you want to use it, you can have it and tailor it to your need. The 30,000 cohort, we recruit them, we mail out a package, information package to them, we set up an appointment to go to their home, we do a 1-hour face-to-face CAPI interview with them at home. In order for them to be included in the comprehensive, they have to agree to do a home interview plus come to the data collection site and do our physical assessment test. If they say no to either of those, we sort of exclude them from the study, we recruit our next person. But they have the option of saying no to the biological sample or the giving us the permission for the data linkage, the health card number. So we go to their home, we do the data collection using CADI and medication and some other questions. And we set up an appointment with them to come to the given data collection site, and they go through the full neuropsychological battery, almost 30 minutes. I just wanted to say we also developed a short neuropsychological battery from memory and executive function that was validated and tested, and we administer it by telephone as well. So we, working with Statistics Canada, now we have national norms for the general population on the memory and executive function and some of the other cognitive features of the population. So these are some of the measures, and again, this is a specialized software we have developed, which is the questionnaire that is being administered, which is the disease symptom questionnaire and the neuropsychological, plus the actual machines. There is no manual entry of data. So let's say somebody comes and goes through a bone density scan through the DEXA, and that machine is integrated with our software. And as soon as the numbers are generated, they are automatically pulled by our software. And there's a whole series of validation tests that are built into our software, and it says numbers are right, wrong, it doesn't meet our standing operating procedures, and at that point in time we can go back and correct it or redo the test or whatever that might be. And if we have time, I can talk about that a little bit later. And all of this information is also coming in real time to our National Coordinating Center, our IT infrastructure, where again we can look at the data quality. And the biological samples, let me spend a little bit time on some of the infrastructure. Now, not everybody has the luxury of having this infrastructure. We were fortunate to get funding to set up this infrastructure across the country. So we have data collection centers, I mentioned. We have 4 computer-assisted telephone interview sites, and 4 because we have 6 time zones in Canada, so we needed to cover all those time zones, and English and French. And National Coordinating Center, we have developed a biobank as well. We have a genetics and epigenetics center and a statistical analysis center where data are being cleaned, manipulated, and prepared for dissemination. Okay. So when a person has completed the home interview, they have agreed to come to the data collection site. They come, they are given, I don't know if you can see in this little name tag, there is a barcode. Their barcode is scanned and they are entered into the database. Their whole demographic profile comes up, and then they go to, you see it here, then they go to a first room where there's a contraindication questionnaires filled out. And basically, for example, we have some people in the lower age groups, and if for some reason they should not be going through an X-ray, that particular questionnaire identifies, and when they go to that room, by mistake, it happens that they go to that room, machine and will not allow that test to happen, it blocks it. So everything is automated. So here they go to first site in this room, they do 2 tests, neuropsychological testing, and that is also computer administered, and the audiology. So this is a room where they do actual hearing test. This is height, weight, waist hip ratio, and then blood pressure and lung function and spirometry. This is our bone density scan where they do the full body density, they do hip scans, they do spine and aortic calcification as well, and also the body composition. Okay. This is where we do some imaging, cardiovascular imaging. This is carotid ultrasound of the individual. This machine is capable of doing some abdominal ultrasounds for if you want to look at the fat composition and things like that as well, but we are not doing that. It can also do echo, so in the future we might do heart function type studies. We do a series of performance testing in our study. There's time up and go, balance, grip strength, 4-meter walk, and a couple of other ones as well. And we do vision testing. We do ocular response, basically looking at the glaucoma type of indicators. And the machine behind takes the picture of the eye and looking at changes in the eye structure as people age. And the basic vision acuity test. And then they go to another station where they do grip strength, and they also go and fill a questionnaire which is all related to the disease symptoms. Then they come to our phlebotomy lab where the sample, urine sample and the blood sample are taken at the end of their whole visit. This whole visit takes maximum of 2.5 hours. So if we would have done all this testing in a healthcare facility, this would have taken them 6 to 8 hours. We piloted it. And that was one of the reasons we created this dedicated location that we can have people come and go within 2 and 2.5 hours. And doing the electronic capture, integrating machines with our software, automation has also sped up some of the data collection as well and increased the quality. So this is a feature. The blood is drawn. It is processed within the lab right there and there. And then once a week, it is put into this shipper, which is a -160 shipper, and shipped to the central location in Hamilton, and then it is stored into these big tanks. And this little cabinet here, we have a series of cabinets which sort of stores filter paper, dry blood samples at the room temperature for DNA extraction. So I won't spend much time on this. We have developed data and sample access policies. We are in the process of developing some of the access forms and what people have to do. And we have actually started already designing ancillary studies, which are sub-studies that require a subset of the population and that will also, which either require new additional data or some data to be collected in order to look at some sort of nested case control studies or other types of studies. And this is our governance and management structure, and I think this has been one of the important things for us, because having this governance structure allowed us to be able to access some private and confidential data from ministries of health in each one of the provinces in Canada, because those data are very private and confidential. And this is some of our core team and the site investigators, and I will end here if you want more. Our protocols, our questionnaires, a lot of detail is available on our website. You just have to enter your name and get a password, which is available to anybody, and you can download all this information. So I went through this information in a hurry. I saw Vincente was doing this to me as I was doing it. So I'm done.
Joao first.
I have two questions.
Yes.
One of them is you said that it was very important to get involved policy working group. My question is, for a 20-year study, how do you deal with politics productivity? In Europe, at least, historically, every 8 years, the government, for all European countries, the government changes, and so it's very hard to, not prime minister or
Yeah. When I talk about policy ministers, I'm not talking about politicians. So if you want policy relevant questions addressed, you want the middle level managers in these different departments, because those are the people who are consistent even though the government changes. Those are the people who actually recommend what policies, there are some political policies happen, and those are the people who actually, at least in the context of Canada, are driving what happens from a policy point of view in our country. Now, you asked a very important question. These policy groups or our working groups haven't been abandoned. They are there. We meet with them every time. So when we go back for the second wave of the study, we might have to change some questions. We will keep the core questions as they are, but we might bring in some new questions that are of relevance at that point in time to the policymakers. And that's where that 30-minute maintaining contact module becomes important, because that doesn't allow us to mess up with the core data collection of the study.
My second question is about ethics.
Mm-hmm.
I assume that after that 2-hour health appointment, you will provide some feedback to the
Mm-hmm.
participants
Mm-hmm.
about their health and about what to do if they see that they have a serious disease.
Yes.
Now that means that your observation will change reality. So how will you deal with that from a methodological point of view?
It is an issue with all longitudinal studies, right? And I think this is one of the reasons I talked about earlier, comment about adaptation. Some healthcare adaptation, healthy lifestyle adaptations are going to happen just because you're studying them. So let's go and measure it. What are they doing? Methodological, see what difference that makes in the long run. And this is not new. Many of the longitudinal studies, there have been papers published forever saying just because you're measuring something changes the health status of the participants. So we are trying to quantify how well we will do it, not sure yet. But we are trying to capture how their life or their health has changed, what new things have done since the last time we saw them, and try to capture those things and see how much. But now we don't know whether they would have done that anyways, or was that function of our study. So it's a complex issue. Now, in our study, one thing to keep in mind that we are not analyzing most of the data right away. So we are giving them very minimal information back. So we are giving them information about things that we can measure and tell them right away. Blood pressure, because we can tell them whether their blood pressure is high or low based on the information we have and compare it to normal. We can tell them something about BMI or obesity. We can tell them about something about the bone density. And so the type of information we are giving them, they would have been caught one way or another by their healthcare provider anyways. We are not giving them that no, we might have some incidental findings. By law, we are required to report. We'll have to deal with those. But the type of information we are giving is a routine clinical information. We are making no interpretation of the data in relation to the diagnosis or anything. We are just making them link it, go and see their family physician if they have one, or make an arrangement for them to go see some sort of healthcare provider.
Thank you.
This was a big debate with our ethics review boards, how much information we should give. And one of the challenges we have, especially some of the research findings we might have in 5 years when the data are analyzed and they identify that these people had some health problem, how do we go back and inform them at that point in time? And when you have many researchers using the data, and our ethical, legal, and societal implication committee, which is composed of lawyers, ethicists, researchers, have been grappling with that issue itself. And that's an issue for most longitudinal studies, not just for us. The UK Biobank is dealing with those issues as well, return of results. So, any other questions?
Any other question?
Yes.
Yeah, if I have understood correctly, do face-to-face interviews with 50,000 people.
No, on 30,000.
What about the other 20,000?
They are only telephone-based interviews.
Okay. Now I have a question about the nationalities, because we have decided a national sample of 20,000 people with telephone interviews, and 30,000
Is of a national scope.
Not nationally representative.
Right.
in great detail, health examination in great detail. I don't know, because I think this is one of the issues that will come up in the debate, how to best use your resources. So, for example, have you examined other scenarios of having a kind of smaller sample but face-to-face interviews and clinical examination for all participants, which was going to be nationally representative? I'm asking this question because I think being nationally representative is one of the key aspects that perhaps LS can sell to the potential funder. So I think
I think there's lots of options we could have taken. We could have done all 50,000 in 2 communities alone and focused on those. That would not have gotten funded in Canada because the politics of Canada come into play. And secondly, I think Spain and UK might have a different advantage that they have population sizes. We couldn't recruit 50,000 people alone in Ontario. And we would have run out of sample with the response rates and things like that we are going. And so it was a logistic and fiscal reality for us, but at the same time, we couldn't go less than 20,000 for our nationally representative sample because we could not give provincial level estimates that had any confidence in it. So it was a balancing act between some of the regional politics as well as the science and the vastness of the country that we have. And actually, the comprehensive, we couldn't have done, the population, let's say in Ontario, is very different than the population on the East Coast or the West Coast. So we picked sites to sort of take the spectrum. Yeah, but you're right, there are many different options we could have considered, but in our case, for many reasons, that option made the most sense.